يعطيك العافيه.
وين تفتح لي هذا لو سمحت؟ وين الميكروفون؟
ابشر.
Assalamu alaikum warahmatullah. So today we're going to talk about the parathyroid disorders. Okay. How many parathyroid glands do we have? Four. Where are they located? Behind the thyroid. So do you know why we call them parathyroid?
They're next to the thyroid. Because originally they were like an embryonic version. They were next to the thyroid, and then they.
What's your name? Who's sitting next to you?
Shahad.
Shahad, can I call you the next to Shahad? I feel bad for the parathyroid, right? They did not give them name, they just named them to the thyroid. And this is one of the big mistakes that people relate the parathyroid to the thyroid. They're just neighbors. They have nothing to do with each other, sitting in the back. They can be compromised in thyroid surgeries. And this is actually how they discover them. That's when they remove the thyroid, they found that the calcium goes very low. So it's one of the last or the latest discovery in endocrine glands in the parathyroids. They didn't know that these glands were existed until they were manipulating the thyroid gland. Okay, so this is just an introduction to know that the parathyroid is very important in which electrolyte metabolism, the calcium. So if you think of the calcium just like a thyroid hormone, we need a TSH to regulate the thyroid hormones. We need the PTH to regulate the calcium. So if the calcium goes low, the parathyroid will go up. The parathyroid hormone will go up. And if the calcium is high, the parathyroid will go down. So this is how to remember the action of the PTH on the calcium is there is a good feedback between the two of them. And why the calcium is important, why we have in this lecture, is not about the parathyroid. Actually, the parathyroid does not cause major problems by itself, but it causes it through the calcium metabolism. So calcium is very important. Why calcium is very important? In what? Mineralization of the bone. More than that, calcium is very important for one big thing. Neuromuscular conduction, the action potential. You need the calcium for the action potential. You need the calcium for the cardiac function, cardiac work, the muscle, the cardiac muscle. Without calcium does not work. Nerves, also conduction. From the central nervous system to peripheral nervous system, it's all work by the action potential because of the calcium. Okay, is the SA node, action potential, calcium. So we need the calcium, and if you have a hypocalcemia or hypercalcemia, the first thing you want to do for the patient is ECG, right? Because this is very cardiotoxic. So this is the importance of discussing the parathyroid. Can affect the bones through osteoporosis or calcification, can affect the heart, the muscles, and blood vessels can have calcification if they have too much calcium, and if you have too low calcium, we have problems. So going to the content, as I said, calcium hemostasis is number one why we're studying the parathyroid, and also we're going to talk about the types of hyperparathyroidism and hypoparathyroidism. Just like any gland, like the thyroid, we have hypothyroid, we have hyperthyroid. The parathyroid also we have high and low. The adrenal gland, we have high cortisol and low cortisol. All of these glands, the dysfunction is either by having too much of the hormone or too low of the hormone. And in this case here, the direct effect is the calcium, too much calcium or too low calcium. So the calcium hemostasis is a complex process involving the following four key components: the serum calcium, serum phosphate, 125 vitamin D, and parathyroid hormone. And more than 99% of the total body calcium is stored in the bone in the form of phosphate, hydroxide salts, and predominantly hydroxyapatite. So the skeleton makes a good reservoir for calcium. So if the calcium goes low because you are not eating enough calcium, you're not taking enough vitamin D, your heart muscle needs to work. So let's get the calcium, get it from the bone through what? Osteoclast, which activate, what hormone activate the osteoclast? The PTH, the parathyroid hormone. Okay. So, you know, for calcium hemostasis, remember glucose hemostasis. So in glucose metabolism, we have the hormone, the main hormone is the insulin, right? But also we have the glucagon. Just if you have the sugar, it goes down, it goes up. So in calcium metabolism, if the calcium goes down, we have the PTH to go up. But if the calcium goes up, we have the calcitonin to get the calcium back into the bones. You see that? And they're sitting next to each other. So we have the calcitonin in the C cells in the thyroid, and behind them we have the PTH cells, the chief cells also. So in both cells we have the calcium sensors. So they sense the calcium state in the blood. If the calcium is low, PTH goes up. If the calcium is high, calcitonin goes up, and vice versa. Same thing in the islets of Langerhans. In the pancreas, we have beta cells sitting next to the alpha cells. If the glucose goes up, insulin increase in production, and if the glucose goes down, the glucagon increase. This is a normal human mechanism to regulate many of the elements in the body. We have usually two powers, one to increase and one to decrease, depending on the hemostasis. So the calcium hemostasis, PTH, goes to three areas. Mainly, we said the bone is number one, stimulate the osteoclast to increase the calcium, and also goes to the GI and kidney to do. In the GI, it does calcium absorption because you just had your milk or vitamin D, you have calcium content, you need the absorption. In the kidney, it's not called absorption, it's called reabsorption because it's happened after the glomerulus filtration in the proximal tubules. Most of the glucose, calcium, sodium goes through reabsorption. So the PTH goes absorption of calcium in the GI and reabsorption of calcium in the kidneys. And when you see that the calcitonin does exactly the opposite of that. This is just like a narrative of what I just said. Bone action of PTH, release readily available calcium from bone, causes bone resorption. Adrenal action of PTH, stimulates reabsorption of calcium, inhibit the phosphate reabsorption. This is also very important. You cannot discuss calcium without discussing the phosphate. Cannot discuss calcium without discussing magnesium, potassium, acid-base balance. Those elements are very important in calcium metabolism, but number one is the phosphate, especially for the PTH. And the way I used to remember this, PTH is phosphate thrashing hormone. So when you see the PTH, it means that you are getting rid of the phosphate and absorbing the calcium. So PTH, phosphate thrashing hormone, PTH, phosphate thrashing hormone. Synthesis of calcitriol. Calcitriol is a vitamin D, 125, and this stimulates the synthesis of 1-alpha hydroxylase in the kidney, and that's the action of the PTH. So vitamin D comes through the skin, goes to the liver, get the ferrous 25 hydroxylation, goes to the proximal tubule through the 1-alpha hydroxylase, get the 1 hydroxylation, and become vitamin D 125 hydroxylation. This is PTH dependent mechanism. If you don't have PTH for any reason, you don't have the activation of vitamin D. Some people are talking about non-classical effects of PTH going to the cardiovascular, like direct stimulation of cardiovascular, neuromuscular, and gastrointestinal, but this is less than 5%. Main action is on the calcium through the bone, GI, and kidney. So this diagram here shows you what I've said about the chief cells in the parathyroid. If you center your attention to the box here, the parathyroid chief cells, it has calcium sensory receptors. It depends on the calcium level. If you have too much calcium, it's negative feedback, negative effect on the PTH secretory granules, low PTH. And if it's low calcium, PTH goes up. And if it goes up, it goes directly to the bone and the kidney and do the activation of vitamin D, as I said, and also go to the GI. Vitamin D 125 is actually through which the PTH reabsorb the calcium in the GI, and it's in the kidney as well. And if you have enough calcium, then you will have negative feedback on the parathyroid cells. Again, bone resorption, release of calcium in the kidney, calcium reabsorption and phosphatic secretion, and calcitriol formation. So the disorders of parathyroid, either you have hyper or hypoparathyroid. So to get rid of the hypoparathyroid is very rare. Just like I want to say a few words about it, it's very rare. You don't see a patient coming to you just walking to the clinic with hypoparathyroid. Most of these patients usually are secondary to thyroidectomy, surgical removal accidentally of the thyroid gland and the parathyroid while they're doing thyroidectomy. That's the most common presentation of hypoparathyroidism. Some cases are congenital, that's in early life, that you will find those patients. But the most common disorder of parathyroid is hyperparathyroidism. And this could be classified as primary, secondary, or tertiary. Yesterday, we talked about the primary disorder of any gland is because the gland itself is damaged. Secondary, that means a superpower. Like for the thyroid, it's a pituitary. So what's the secondary for the parathyroid? The calcium itself. Is the calcium low due to kidney problem, due to vitamin D deficiency, malabsorption, GI malabsorption, anything can be secondary causing low calcium, that's secondary. Tertiary is what? In the thyroid, we said tertiary is the hypothalamus, right? The TRH problem. But tertiary in the calcium, we refer this to rare presentation of end-stage renal disease. When you have secondary hyperpara due to renal insufficiency, stay for a long time. Stimulating the 4 parathyroid glands become hyperplastic and autonomous production regardless of the calcium level. Even if you correct, even after kidney transplant, some patients can still have tertiary hyperpara. Okay? So primary hyperpara is the most common, and it is predominantly a disease of postmenopausal women. Like most of these patients are women after the age of 50. 85% is due to a single adenoma, and 14% due to hyperplasia, and it can be associated with main type 1 syndrome. Clinical features of primary hyperpara: asymptomatic most of the time. Features of hypercalcemia: sometimes this could be incidental findings, like you do lab work for the patient and you check the calcium and the calcium is high. Then you do the PTH is high, so it can be accidental finding. And sometimes it's as part of the end organ damage due to osteoporosis. Like a patient presented with osteoporosis, you have to do the workup completely, including vitamin D, calcium, and PTH. And accidentally, you might find that the patient has primary hyperpara. Secondary hyperpara, that's usually, as I said, due to renal insufficiency, due to low calcium, secondary to renal impairment, vitamin D deficiency, GI disorders, example malabsorption. And the clinical picture of hypercalcemia depends on the level of hypercalcemia, mild, moderate, or severe. So mild, asymptomatic, could be non-specific symptoms, constipation, fatigue, depression. It's becoming moderate. You can have acute polyuria, polydipsia, dehydration, anorexia. This is similar to what? Hyperglycemia, remember? So it just have the same effect. The calcium has the same effect in the kidney, becoming like diuretic, like glucoseuria, hypercalciuria, give you acute polyuria, polydipsia, dehydration, anorexia, nausea, muscle weakness, and change in sensorium. When severe hypercalcemia, you can have severe symptoms of polyuria, polydipsia, dehydration. The same above symptoms can be very severe, and severe weakness and muscle weakness. Complications of hyperpara can affect this calcium. Hyperpara affect through the calcium itself. Can give osteoporosis because you stimulated the osteoclast, bone resorption. Affects all sides of the bone, but predominantly cortical bone in the periphery is more affected. And in the X-ray, it's uncommon to find, like, send patient with hyperpara for X-ray to characterize the bone involvement, but you can see some bone characteristic on the X-ray, sometimes bone cyst, and in rare occasions you can have osteitis, fibrosa, cystica, and those usually in tertiary hyperpara. Complication of hyperpara, again, affecting the joints because of the hypercalcemia or calcification of the cartilage. You can have chondrocalcinosis and pseudo-gout presentation. Patient coming with arthritis pain, and you work up, you should include the calcium. Calcium is high due to PTH, can give you pseudo-gout presentation. Kidneys, if the calcium goes high in the kidney, renal stones, nephrocalcinosis, calcification of the renal tubules, and renal impairment. Etiology of hypercalcemia depends on the origin. So if you have patients with hypercalcemia, in order to treat, you have to classify what's causing this. Is it hyperpara? Okay. Is it PTH is high? Is it primary, secondary, tertiary? And if the PTH is low, then you think about malignancy, and malignancy could be ectopic hypercalcemia or bone metastasis. That's why the calcium is up. Less common etiology of hypercalcemia, vitamin D intoxication. Patients who are being given vitamin D and they continue on it without monitoring the vitamin D level, they can go to vitamin D intoxication and causing hypercalcemia. And some rare cases with familiar hypocalciuric hypercalcemia, FHH, those patients, and we will see in another slide, that they will have high calcium level in the blood, but low in the urine. And that's what the name says. And sarcoidosis and granulomatous diseases also can give you hypercalcemia, but those will have low PTH because the driving force here is not the parathyroid, it's actually the granulomatous disease. Uncommon causes of hypercalcemia, patients taking thiazide, that's very important in the medication history to ask about medication that can increase the calcium, thiazide, lithium, patient in immobilization, bedridden, like if you see a question in the exam and just stand saying elderly, bedridden, fracture hip, and then the calcium is high, most of the time this is because of immobilization. Addison disease, low cortisol also can increase the calcium, and vice versa. If you have too much cortisol, you can have low calcium, and that's why we use steroids to treat some patients with hypercalcemia, especially in vitamin D intoxication. And vitamin A intoxication also can give you hypercalcemia. So the lab workup of calcium disorders, any problem with the calcium, these are common lab that we order. We need to know about the serum calcium, phosphate, serum PTH, and vitamin D. Those number 3, they should come up on the list. Like all are correct, but number 1, you need to know the serum calcium level, second by the phosphate, then PTH, vitamin D. Because if you have those 3, you can tell if this is PTH, hyperpara, or low PTH, hypercalcemia. So the big difference. Again, you need to know what's happening in the urine. You cannot diagnose primary hyperpara without urine calcium because FHH can give you presentation of high PTH, high calcium, but low urine calcium. So with a patient still might have an adenoma, but before removing that adenoma, you have always to check the urine calcium to prove that you have a hypercalciuria in all patients with primary hyperpara. And also you need to know the serum creatinine or GFR, kidney function, very important because it could be all what you see in the hypercalcemia or hypercalciuria is renal insufficiency. We order vitamin D125 and PTH-RP if the PTH is low. You have high calcium, low PTH, then you have to think of outside the parathyroid glands, look for the vitamin D125, and vitamin D125 give us what disease? Sarcoidosis. Granulomatous disorders can give you hypercalcemia through what? Anybody knows? Activation of what? 1-alpha hydroxylase. Activation usually happen where? In the proximal tubules, right? But in sarcoidosis, it does not happen in the proximal tubules. This activation happen where? In the lungs, the ACE. Say the ACE inhibitors. Okay, so we have ACE, and this ACE can activate through the inflammatory cells, can activate the vitamin D25 to 125 and increase the calcium. So you'll have high hypercalcemia, but the parathyroid PTH is low, but the vitamin D125 is high. Okay? So we save the vitamin D125 only if the PTH is low, but we always order vitamin D25 in patients with hypercalcemia. 125 only if the PTH is low. PTH-RP, we don't order it unless the PTH is low. If we're thinking of malignancy, you have to do PTH-RP. PTH, because RP means what? Related peptide. So it looks like PTH, but it's not PTH, but produced by the tumor cells. But give the same action on osteoclast, bone resorption. So this slide here is very important, and you will see one of it in the exam and in real life. When you have a hypercalcemia, you check the PTH and the PTH came high. So in this first three examples, PTH is high, and the last one, very low PTH. So those first, let's go about the first example. We have high PTH, high calcium, low phosphate, and high urine calcium. This is primary and tertiary hyperparathyroidism. This is how it looks like. We have high calcium, low phosphate, and high urine calcium. Make sense? We can explain each one of them. Why high calcium? Because we have high PTH, right? Why low phosphate? Because of high PTH. Why high urine calcium? Because of high serum calcium and high PTH. And we don't have any problem in the kidneys, in the kidney function, or in the calcium sensing receptors in the kidneys, in FHH. Those are rare familiar disorders that will give you low calcium in the urine. So this is how we identify primary and tertiary hyperparathyroidism. Number two, secondary hyperpara. Secondary to low calcium because of low vitamin D deficiency. So it gives you low to normal calcium, low phosphate, low urine calcium, and high PTH. Why low to normal calcium? Because we don't have enough vitamin D to absorb it. Why low phosphate? Because high PTH. Why low urine calcium? Low serum calcium. And why low serum? Because low vitamin D. Renal failure give you also high PTH. And renal failure, we have to differentiate. Is it early in the game or late in the game, right? Because early in the game, you have low calcium, high phosphate, low urine calcium, and high PTH. Why low calcium in renal failure?
Yeah.
Because the kidney does not activate the vitamin D. The proximal tubule is not working anymore, right? So you will have low calcium. And you have, at the function of the calcium, the kidney also to reabsorb, it's not doing it. So it's not doing it because it's failing in general, and it's also because of the loss of activation of vitamin D. Why high phosphate? Because the kidney is supposed to get rid of the phosphate. Okay. After you eat all these proteins, all these meats, when you break down those DNA, those amino acids, purines, you have to get rid of the phosphate. Some of it goes through the urine, and some of it gets recycled and make new, endogenous amino acids. So most of it actually get rid in the urine. But if the kidney is failing, phosphate accumulate. And if phosphate accumulate, PTH goes up because to get rid of the phosphate. Number three, FHH, familiar, so it runs in family, hypocalciuric, low calcium in the urine, hypercalcemia, high calcium in the serum. So high calcium, normal phosphate, normal or high PTH, but the most important is low urinary calcium. That's the hallmark about this FHH. And we have to rule that out in all cases of primary hyperthyroidism. We always have to make sure the urine calcium is done.
There's specific receptors that's affected at primary hyperthyroidism.
Yes. It's actually, that's why it's not like getting rid of the calcium in the urine. So calcium in the urine go through special receptors. When you have enough calcium, it goes out in the urine. But in these patients, this kidney calcium receptors is not functioning. This is genetic defect in those patients. And usually it's heterozygous, like the father has it, pass it to the kid, will have like, usually it's benign. You just find it like rarely, you'll find it just hypercalcium a little bit, high PTH, but you think of primary hyperpara and you find this is like, it's not affecting, it's not like causing osteoporosis causing problems or this is minor defect. But some patients will have homozygous, that means they got the gene from the father and the mother, and the newborn will have a very bad hard time when they are born, hypercalcemia from day one, because they cannot get rid of the calcium in the urine. Number 4, hypercalcemia of malignancy or vitamin D excess. So PTH should be low because it's parathyroid is a victim here. It's not like causing any problem. It's a problem is coming from the outside the parathyroid, either too much vitamin D, too much calcium, malignancy also affecting the bone resorption, too much calcium, so high calcium, low normal to high phosphate, high urinary calcium, and elevated PTH-RB in malignancy, and elevated vitamin D and vitamin D intoxication. Any questions so far in the pathophysiology? Treatment of hyperpara depends on the calcium level, mild, moderate, or severe. Observation, most of these cases, we don't have to intervene. Asymptomatic patients, mild hypercalcemia, elderly, surgery is contraindicated, so we just observe. Most of patients with primary hyperpara, they have parathyroid adenoma, they're young and symptomatic. Because of severe hypercalcemia, we send them for surgery, parathyroidectomy. And some patients, we have to do medical approach first before we do surgery, or medical would be the only thing we cannot do surgery. So we adequate hydration, vitamin D intake, assessment, and physical activity if they are bedridden. And the medication that lower calcium, for example, calcium mimetic cinecalcet and bisphosphonates. Those can lower the calcium and can be used acutely or on chronic management of hypercalcemia. The hospital management of acute hypercalcemia, hydration, remember glucose, okay, hyperglycemia, just the same thing, same treatment, give hydration, trying to get rid of the calcium in the urine, and inhibition of bone resorption. As I said, we can use bisphosphonate, zanidronic acid, or can use calcitonin injections. And in some cases, we can use steroids, vitamin D intoxication or malignancy. And in very rare cases, we might need to do dialysis on these patients. And this one slightly, I give some answers, some of the questions about FHH. It's 2% of all asymptomatic hypercalcemia caused by FHH, autosomal dominant, due to mutation in the calcium sensing receptor in the kidney, benign nature, does not benefit from parathyroidectomy. Homozygous states produce severe life-threatening hypercalcemia soon after birth, and low urinary calcium excretion, calcium creatinine excretion ratio. Remember in diabetes, later we'll see that albumin creatinine ratio. Here we do calcium creatinine ratio. And if it's very low, that means we have a gene defect, FHH. If it is normal or high, this could be primary hyperpara. We finish hypercalcemia, we go to hypocalcemia. As I said, calcium is very important for neuromuscular conduction. And if we have any low calcium, this is the main presentation: tetany, neuromuscular irritability, could be mild, could be severe, less specific symptoms, fatigue, hyper irritability, anxiety, depression, but no neuromuscular symptoms in the acute phase. Neuromuscular symptoms can happen later if it's becoming chronic. As I said before, other factors affecting the low calcium could be low magnesium, low potassium. So if you have low calcium, you have to check potassium level, magnesium level, and try to correct them before you give patient calcium. Signs of acute hypocalcemia. Those are Chauvet-Stokes sign, Trousseau sign, that's a blood pressure cuff, and that's your carpopedal spasm, QT prolongation, torsade, papilloedema, psychiatric manifestations. So it's all about neuromuscular, whether in the heart, in the brain, and in the musculoskeletal. It's becoming chronic. Hypocalcemia, it affects the bone, especially in the childhood, give you rickets. In adults, give you osteomalacia, can give basal ganglia calcification, causing Parkinsonism, dementia, could be asymptomatic, found just doing an MRI and find this basal ganglia calcification, ocular, cataract, dental abnormalities, of course, and ectodermal manifestation in the skin and in the hair follicles. So we've finished, and we will have two cases before we go to the thyroid.
Why would there be classifications in hypercalcemia?
And that's a very good question. Actually, usually with hypercalcemia, you get the calcification in the blood vessels, but in the basal ganglia, it's actually a rare. It's called the paradoxic phenomenon. It will have the hypercalcification, and it's not like clearly understood, but this is a very common. It's just attract the calcium, and that's cause actually worsening the hypercalcemia. Can somebody read this case for me? Who want to go for this? Yes, please.
58-year-old female who is known to have hypertension and type of diabetes mellitus, found to have mild hypercalcemia on routine chemistry. Medication includes metformin and ACE inhibitor. Her laboratory shows calcium 2.05, phosphate 0.5, urinary calcium 300, parathyroid hormone 95. Which of the following diagnosis fits this clinical picture?
Okay, number one, familiar hypocalciuric hypercalcemia. Urinary calcium is what? High. So A could be primary hyperpara. Could it be secondary hyperpara or secondary hyperthyroidism? Vitamin D deficiency? Could it be?
Yeah, because ACE.
Calcium is high, so it does not fit with the vitamin D. Usually, vitamin D you will have low to normal calcium, right? The PTH will go up trying to correct that, but rarely overcorrect. Usually in the normal side or the low normal side when vitamin D is deficient. I see a lot of cases that's in my clinic practice. They're referred by other doctors or they've been seen by other physicians. They always order vitamin D25 and PTH and calcium level. And most of the time they get referred to us because of high PTH. But you have the answer. You have high PTH because of the low vitamin D. If you correct vitamin D, you correct the low calcium, and then PTH will go down. Okay. ACE inhibitors, somebody said that. It does not. ACE inhibitors work in the kidney, okay? And that's lower the blood pressure. But the ACE we talk about is extrarenal activation of vitamin D, 25 to 125, happen in the lungs. Case number 2. One from the back, can you read? Yeah, go ahead.
A 60-year-old male was recently diagnosed with chronic kidney disease stage 4. Was found to have hypertension and routine medical checkup. His lab was likely shown in each of the following factors.
So what's the key word here? Recently, right? So this is early. No, it's not. It's early kidney problem. Late kidney problem, we're thinking about tertiary. So tertiary, everything is high. High PTH, high calcium, high phosphate, right? Okay. Early is caused by low calcium, high phosphate, and low urinary calcium. So the answer is B. Anybody says anything different? All right, so this finish the parathyroid disorders. Any question before we go to the, we'll have like 5 minutes break before we go to the next lecture.
Okay, the last question. The patient was diagnosed with stage 4.
Mhm.
I know the word recently is there, but it's like stage 4 wouldn't be a prolonged kidney disease. It's happening for a very long time. Why don't we think of it as a tertiary?
Usually tertiary happens is like usually patient on dialysis. Okay, most of these tertiary patients is already end stage and has been chronic in dialysis for long period of time and have high levels of phosphate for long period of time, and the 4 glands will becoming hyperplastic and autonomous production of PTH. So it happens after years of kidney failure and on dialysis. Okay. All right.
Is it great though?
Yeah, break time, yeah. Mhm. Biraz barang itu penting. Saya barang. السلام عليكم. خلاص هنبدأ إن شاء الله. Let's start the clinical manifestation and management of thyroid disorders. So this is a continuation of what we discussed yesterday about the thyroid. And this is going to be like, we all going to participate in this lecture. Every one of us should be ready to answer a question or to give a question, okay? So when we talk about thyroid, we have to mention the hypothyroid, clinical and subclinical, hyperthyroid, clinical and subclinical, thyroiditis, goiter, thyroid nodules, and thyroid cancer. If we can divide, the content will be this thyroid dysfunction and thyroid structural problems. So we have problem here in the physiology or problems in the anatomy. Start with the physiology. As we said yesterday, we have a positive and negative feedback between the T4, T3, and TSH, and the TRH in the hypothalamus. T4 is the main thyroid hormone. The ratio is 15 to 1. And T4, if you lose one iodine, it will become T3 in the liver and in the brain. Thyroid receptors are available in almost all the cells of the body. Every single cell in the body needs thyroid hormone. So if you have hyperthyroid or hypothyroid, the symptoms and signs can be all over the body. So any patient that's come to the clinic or to the ER or in the hospital have any problem, you are not going to be faulted if you check the TSH. Patient coming with depression, you can check TSH. Patient coming with psychosis, TSH. Abdominal pain, constipation, diarrhea, TSH. Heat or cold intolerance, TSH. Weight loss, weight gain, TSH. Fraction, TSH, osteoporosis can happen because of thyroid toxicosis. So basically, hair loss, everything. Periods, irregularity, get a TSH, thyroid. Pregnancy, unable to conceive, a TSH. Don't forget the TSH. Most of the time, patients goes around and around because of weight gain and the problem in the thyroid. Goes around and around for the infertility, problem in the thyroid. So thyroid affect we have thyroid receptors in each cell of the body. So thyroid disorders usually affect one of the two following: thyroid function and structure, as we said. And single most important test is the TSH. High TSH usually is hypothyroid, and it requires treatment with levothyroxine if we confirm the diagnosis of hypothyroidism. If we have a low TSH, usually it's hyperthyroidism, but it could be also in 1% of the cases central hypothyroidism. But most of the time, it's hyperthyroidism. And if it's hyperthyroidism, most of the time you need to know the cause of the hyperthyroidism, and the next step will be thyroid uptake and scan. And there are many exceptions, as I said. Goiter or nodule detected on history or physical exam, or nowadays, what's number one cause of detection of thyroid nodule? Nowadays, patients go to the hospital for headache, stroke, any major problems in the head and neck or chest. What they do? CT scan, right? So because of the use of the CT scan, in many patients in the ER or in the clinics, we get referral as endocrinologists because of thyroid nodules, because incidental finding on neck imaging. That's number one cause of why we see those cases like increasing in practice. Suspicious thyroid nodule on the CT, the next step should be ultrasound, because ultrasound is superior to CT in defining the thyroid nodule, whether it is benign or malignant, based on the look and the shape and the vascularity. We can tell from the thyroid ultrasound if this is high suspicious for thyroid cancer or not. But the most important thing in any cancer diagnosis is the tissue. Tissue is the issue. Always put a needle and get some tissue and examine under microscope and look for the malignancy characteristics. So case number one, who wanna go first? Okay, go.
59-year-old lady presented to the physician with 2 months history of palpitation, tremor, and weight loss. Examination revealed tachycardia, tremor, and moderately enlarged thyroid. No exophthalmos. What is your working diagnosis? It could be hyperthyroidism, but toxic.
So this is problem of the function of the thyroid or structure of the thyroid so far?
Function.
Function of the thyroid is two things: hyper or hyper. So this is, we know when we read so far here, this is hyperthyroid. So I need to do something, right? I need to confirm this. Do I need more symptoms? So I'll continue asking the patient in the history. Do you have this? Do you have that? Do you have this? Do you have that? Okay, just to get more. Then I will examine the patient. I'll look for physical exams in the eye, in the skin, tremors, palpitations, look at the heart rate, ECG. So I need more information from the clinical picture, clinical presentation. Then I may need to confirm with the lab test. I need to do TSH, free T4. If I'm suspecting hyperthyroidism, I always have to order free T4 and free T3. Antibodies, thyroid ultrasound, thyroid uptake. If you want to be a good doctor, please don't do this. Don't order everything. I work in different places. I see that they just have the list. They order them. Order what you need. And the most important, and the exam is not forgiving. In the exam, what's the next step? You could have 5 options. All are correct. But there is a sequence. Why you choose this over the other one? Why you choose? Because this gives you more information to treat. This is cost effective. This is the most prevalent, epidemiologically wise. This is step here. Give us more information, treat more people than one person. So there's always a reason why there is a best answer. And in clinical practice, you have to follow this also. You have to pick, don't just order TSH 3-4, thyroid ultrasound, thyroid uptake, and send the patient just go all shish kebab. Just do everything. No, one by one, because the exam is not forgiving. So what other symptoms and signs you need to screen for the history? I always like to compare hyper and hypo, and it's very important to tell the patients about hypo and hyper symptoms. Why? Because if you treat hypothyroid too much, can send the patient into hyperthyroidism. So I tell them, monitor for this. If I give them levothyroxine, I tell them monitor for the symptoms of hyperthyroidism. And if they're hyperthyroid, I treat them with antithyroid medications. I always tell them, monitor for overtreatment, symptoms of hypothyroidism. So be prepared. Hypothyroid, fatigue, hyperthyroid. You are hyperthyroid, so you're active and you have a lot of energy, or you have fatigue.
Because in the beginning you're like that, and then you come.
Fatigue, I mean both. Okay, even though it's hyper, it's still exhausting. You'll be sitting and your heart is behave like running a marathon, like it would be 120, and your muscles is contracting all the time. You have tremors, you're anxious, you're overexhausted. So hypothyroid, you have also low energy for a different reason, because you don't have the fuel of the cells. Hypothyroid, weight gain because of low metabolism. Hyperthyroid, weight loss. Hypothyroid, cold intolerance. Why cold intolerance?
Yeah.
People in the back, why like cold intolerance for a patient with hypothyroid? How the thyroid affect the temperature? So I didn't hear anything. Yes, what does it do to the metabolism?
No metabolism because of loss of sodium does it.
So it affects the thermostat in the body, right? And that's the thyroid is the reason why even if we go to a very cold extreme weather, still your in-core temperature is going to be 37. Very important thyroid hormone to maintain this temperature and to maintain the metabolism of every single cell in the body. Through the mitochondria, you need a touch of thyroid hormone to keep the fire, shu'la, to be going, you need the thyroid hormone. So cold intolerance for hypothyroidism. For hyperthyroidism, it is heat intolerance. Hypothyroidism, you will have constipation. Why constipation? Hmm? Mhm. Decreased bowel movement, yeah, because everything is slow. Your brain is slow, your muscle is slow, your GI is slow, everything is slow. Water retention, and the opposite, everything is active. In the hypers, you will have loose stools. In hypothyroidism, depression. In hyper, anxiety. In hyper, dry skin. In hyper, yes, oily skin. Palpitations in hyper and tremors. Hair loss. Hyperthyroidism can give you also hair loss because turnover of cells is going fast, not giving enough time for the cells to regrow. Signs suggestive of thyrotoxicosis. On exam, goiter. Okay, goiter, is it specific for hyperthyroidism or hypothyroidism? Can you find it in both? Why? Why if you see a patient with Hashimoto thyroiditis, hypothyroidism, why the goiter is enlarged? Why the thyroid is enlarged?
Increase in TSH.
Hmm?
Increase in TSH.
Yes, in TSH, what does it do to the thyroid? Two things. Through the receptor, TSH receptor, it turns on the thyroid function and structure, increase the numbers of cells, hyperplasia, hypertrophy, and also the function of the thyroid. That's why they have goiters in areas with iodine deficiency, high TSH give you a goiter. Areas of autoimmune thyroid disorder, hypothyroidism, TSH is high, give you the goiter. And in Graves' disease, the thyroid is enlarged because of TSH receptor antibodies stimulating also the thyroid. The difference between the two, the Graves' disease one would be like very stiff and hard and firm. Actually, I shouldn't say hard in malignancy, firm. But the goiter in hypothyroid is usually soft. And improve actually with the lowering the TSH. Does not disappear completely, but it improve in size. So signs suggestive of thyrotoxicosis in a patient, sinus tachycardia, atrial fibrillation, and that's why we do in those patients ECG, right? Tremors, hyperreflexia, muscle wasting. So I list this and I want you to think of the mechanism so you don't forget it. Like you don't need to memorize when you understand. If you understand the mechanism, you expect things. You know, okay, you just think of the body and the thyroid receptors are available throughout the body, so the symptoms could be everywhere. So in the muscles, tremors, in the joints, hyperreflexia, in the muscles, wasting, in the skin, warm because of the temperature, could be erythematous because of the increased blood flow to the skin, moist skin, alopecia, as we said, because of the hair loss, nail friability, separation from the bed, hyperventilation, Everything is increasing. Eyelid retraction. Why?
Position of the antibody.
Somebody said the antibody deposition.
It's reflex.
Okay. Sympathetic system stimulated by the thyroxine, right? Like everything. So you will have eyelid retraction, increase the muscle contraction, okay, separating, and you can see that. But the deposition of antibodies behind the eyeball, that's give you glycoprotein deposition, that's give you exophthalmos. So there's difference between a stare look and bulging or exophthalmos. Two different mechanisms. Eyelid retraction, lead lag, because it's so slow, it's coming back. Persistent stare and diplopia. And diplopia because of what? Deposition of glycogen behind the eye muscles. So if you want to look this way, plus you will have some muscles not working in harmony. So you can see two pictures, because one eye is focusing this way and the other one is not turning at the same time. So we'll have two focuses, two foci for the picture. So we'll have double vision, and that's called diplopia. Hyperactive bowel sounds is expected in those patients. So case one, continue. One in the back. Any one of you. The one is sleeping down there. Just wake her up. Yeah. Yes. Can you read case one, continue, please? Okay. Yes. See, even she was sleeping, still she came out with the right answer. TSH. So TSH was very low, undetectable. 3T3, 3T4 was all were high as well. You confirm patient is clinically and biochemically hyperthyroid. How do you know what type of hyperthyroidism? Same person. FT4 is high, TSH is low. So what's the diagnosis? Low TSH, high 3T4, 3T3. Hyper or hypo? Hyperthyroid, right? So what's the differential diagnosis for hyperthyroid? Yes, but what's the differential diagnosis? What caused this problem? Like primary in the thyroid, what's the main disease that causes hyperthyroid? Graves. Number two, toxic multinodular goiter or toxic nodule. Number three, thyroiditis. Okay. Number four, exogenous use, factitious use. Some people use supplements that contain thyroxine in order to lose weight. So that can give you low TSH and high T4 and high T3. Okay. So in order to differentiate between those three or four causes, the next step would be radioactive iodine uptake. Okay. You can do antibodies. Antibodies can help you to differentiate between Graves and toxic. In toxic multinodular goiter, usually the antibodies are negative. In Graves, it's positive. Besides, in Graves, you see the goiter that's firm, and you can do an ultrasound as well. But the actual where the money is the thyroid uptake and scan. So I-123 is the best imaging agent for assessing thyroid function and assess the physiology and to less extent the anatomy. And we talked about that yesterday, right? So the physiology, it gives you information about the uptake, how much uptake, percentage-wise, in 4 and 24 hours. And the anatomy can show you the image, and from the image, you can tell whether this is like a Graves or thyroiditis. What's Graves and thyroiditis? Graves will be looking like Christmas tree. Everything is lighting up, right? In thyroiditis,
There's no.
nothing. So this is the extreme. Graves, full uptake, high uptake, thyroiditis, low uptake. Toxic multinodular goiter, patchy uptake. Toxic nodule, one uptake, lighting up, and the rest is dark. Why? Because all the radioactive iodine is going to here, and this nodule is doing the work for the thyroid, giving too much of T4, and the rest of the thyroid becoming inactive. That's why it's not taking the uptake in toxic nodules. And I'll show you the picture in a second. So high uptake diffusely is in Graves, low uptake in thyroiditis, patchy in toxic multinodular goiter or toxic adenoma. There is no reason to order scans in hypothyroid patients. And we said that yesterday, right? We don't do thyroid uptake in hypothyroid because it's not active. It's not going to take the radioactive iodine. Differential diagnosis of hyperthyroidism. If we have high uptake, toxic adenoma, toxic multinodular goiter, TSH-SHOMA, HCG-mediated hyperthyroidism. So everything that stimulates the thyroid itself, okay, thyroid itself is very active, that's give you high uptake. Graves, toxic adenomas, tumors that in the pituitary that increase the TSH, affecting the thyroid, HCG-mediated hyperthyroidism, that's tumor producing HCG, let's go to the thyroid, give you high uptake. Low uptake, thyroiditis in general, give you low uptake, right? All of them. Patients taking thyroid hormones, not telling us. Thyroiditis, whether subacute, postpartum, painless, radiation thyroiditis, exogenous thyroxine, excessive replacement, factitious, or stroma ovary. And this is what I explained in the image. The one in the middle, Graves' disease, that's full uptake. The one down there on the right, that's no uptake, that's thyroiditis. On top of it, the patchy uptake, toxic multinodular goiter, toxic nodule or hot nodule, when there is one uptake in one area of the thyroid and the rest of the thyroid have less uptake. An autonomous nodule, same thing, it could be the whole thyroid lobe is producing and taking care of the thyroid production. That's why it's very radioactive, but the rest of the thyroid or the other lobe is not seen and suggestive of autonomous nodule. And if you see an area of uptake and in the middle of that uptake there is a no uptake, you compare that to the thyroid ultrasound and there is a nodule on the right side and there is called low uptake at some point, this could be a cold nodule. Sometimes the patient have, especially in exams and real life, patient have a left thyroid nodule and they have low DSH. And you send them for the thyroid uptake. And they have a cold nodule on the right side. Or not cold, they may not call it cold nodule, they may say less uptake. So it's very important to compare the thyroid uptake scan with the thyroid ultrasound to see if that nodule is actually on the same area shown in the uptake. Because you can have multinodular goiter, different 3 nodules. You need to know which one is the cold nodule, because this nodule is the one that needs to go for biopsy. We don't biopsy hot nodules because most of the time they're normal. But the biopsy of a hot nodule give you a picture that's similar to malignancy when it is not malignant. So you don't want to go for biopsying a hot nodule.
It's great.
This is Graves because of 60% uptake at 24 hours and normal 10 to 30%, and this homogeneous uptake. So hyperthyroid Graves disease. Only one thyroid disease causes this Graves, right? And this patient has exophthalmos. This is plus stare, plus lid lag, plus all of them. Okay, so it's not full blown. But why we call this exophthalmos? Because you see there's a bulging of the eye. These patients, I don't treat them in the clinic. I send them to the ophthalmologist, especially for assessment. They can measure, they can put them, and they can measure how many millimeters they're out, and they can follow up with the treatment. Treat them with steroids. And of course, we treat the underlying cause by giving antithyroid medication. Graves disease is a toxic diffuse goiter, most common cause of hyperthyroidism caused by thyroid stimulating immunoglobulins, and mainly in young adults aged 20 to 50, 5 times more frequent in women. And this half of the cases have infiltrative ophthalmopathy with exophthalmos, not seen with other causes of hyperthyroidism, and 5% have pretibial myxedema. And the eyes symptoms and signs that worsen by smoking. So it's very important to counsel patients and stopping smoking. And very important also in these patients, if we treat them with radioactive iodine ablation, they can worsen also the eye symptoms. So they need to be counseled before any treatment for Graves disease that's not medical. So treatment, medical, using antithyroid medications. And sometimes we use symptomatic treatment, beta blockers. Beta blockers are not antithyroid in a sense they do not work directly on the thyroid tissue. They work on the sympathetic system. So they block the effect of the thyroid hormone in the sympathetic system. So patient is anxious, can help. Propranolol, 40 milligram once a day of PID. That's lower the anxiety of the patient, lower the tremors, lower the heart rate. It's just like giving Benadryl to a patient with pneumonia. They have fever, you give the antibiotic, and you give paracetamol, right? For the symptomatic relief. For thyroid, we give the antithyroid medications, but also we give beta blocker for the symptomatic relief. So the antithyroid medications, mainly we have the metimazole, carbimazole, numarcazole, all of them in the same class. This is a drug of choice. We use PTU, propylthiouracil, only in the first trimester because it have a black box warning for liver toxicity. We don't use PTU anymore unless it is the first trimester because metimazole is not. Yes, metimazole is tetragenic in the first trimester. So try to avoid it and we switch the patient. If she was like pregnancy, counseling, we stop the metamazole and start the PTU in the first trimester. And metamazole is stronger than PTU. 5 milligram equals to about 50 milligram of PTU. There are risks of two things: agranulocytosis, low white count, and elevated liver enzymes, hepatitis, with chronic use of antithyroid medication in high doses. So we have to counsel the patient about this if they got like any upper respiratory infection or something. So if you see something in the exam on real life patient on antithyroid medication coming because of recurrent upper respiratory infections or skin lesions or anything that's caused by low white count, low immunity, or increased liver enzymes. So periodically we have to check CBC and liver enzymes. Radioactive iodine ablation, and actually this is the method of choice for treatment in the US. In Europe, they go with the medications first, and Middle East also medication first, but the medication of the treatment of choice is the radioactive iodine ablation. Because the antithyroid medication does not treat like overnight. It's not like antibiotic you give for 1 week or 2 weeks. This is a 2 years treatment until you call it remission, and it might come back. So it's very difficult to get rid of the hyperthyroidism by just treatment or medications. So radioactive iodine ablation is given radioactive material to the patient based on the size of their goiter, try to kill the thyroid tissue slowly, and patient most of the time they go to hypothyroid, and we give them levothyroxine. We found it's easier to manage patients on levothyroxine than on antithyroid medications. We avoid contact with pregnant women and small children when we give this medicine because it's teratogenic, and there is long-term likely to become hypothyroid and need levothyroxine. The last treatment of choice and rarely used is surgery. And surgery, we save it for patients with goiter and compressive symptoms or cosmetic reasons. We don't do surgery for hyperthyroid. It's a last thing to choose in the exam, okay? We save it, as I said, for if the patient have a cold nodule or have allergy to antithyroid medications, or there is contraindication to radioiodine ablation, for patients with large goiter and compressive symptoms, or patients also might need a surgery for the orbital decompression to relieve the compression of the optic nerve in some cases. Smoking cessation counseling, very important in patient in Graves' disease and Graves' eye disease, and associated with worse prognosis. Thyroid storm is an acute form of hyperthyroidism. It's a life-threatening emergency, 30% of mortality, even with early recognition and management. Exacerbation of thyroid toxicosis precipitated by stress, like a patient has Graves' disease and going through surgery, got an infection, pneumonia, car accident, anything can precipitate the patient to go through thyroid storm. So you have to be careful when you take the history of the patient, if they have hyperthyroidism, and especially the untreated, the patient who stopped treatment or ran out of their treatment, they are at risk of going to thyroid storm. So it's very important in the exam or in real life to get the history of the patient of hyperthyroidism. Are they taking the medication or not? Because they can just go into thyroid storm. And signs of thyroid storm: high fever, agitation and confusion, tachycardia, or atrial fibrillation, or any arrhythmias. We finish the hyperthyroidism, go into subclinical hyperthyroidism, and that's when you have low TSH and normal T4 and T3. And patient might be asymptomatic. as well. So do we treat or not? We treat if the patient is above 65 of age. Why? Yes, to prevent osteoporosis of those patients. And the other patient population that we need to treat subclinical hyperthyroid.
Pregnancy.
That's hypothyroidism. And pregnancy. Hyperthyroidism also need to treat, but the main thing cardiac cases. If the patients have atrial fibrillation and they have low TSH, normal T4, T3, and they have cardiac problem, we might need to treat because this could be causing cardiac muscle toxicity. So cardiac disease, heart failure, arrhythmias, ischemic heart disease, osteoporosis or osteopenia, patient above 65 of age, we need to treat. Hypothyroidism, there are different types. The most common one, 90% of the cases, chronic autoimmune thyroiditis, Hashimoto thyroiditis. But you can see some patients after surgery, thyroidectomy or subtotal thyroidectomy, they have hypothyroidism. Patient who had gone for treatment for hyperthyroidism, radioiodine therapy. Patients in iodine deficiency state, some drugs, infiltrative diseases like amyloidosis, carcinomas. Some patients have transient hypothyroidism, painless, silent lymphocytic thyroiditis, subacute granulomatous thyroiditis, postpartum thyroiditis, all these types of hypothyroidism, I don't care. I just give treatment for hypothyroidism. If you see this, just don't focus too much on the underlying cause. Patients have high TSH, low T4, just give the treatment. Thyroiditis is a thyroiditis. Most of the time they go to hypothyroidism or it's self-limited and improve. If they improve, you just stop the medication. Two drugs that can cause secondary hypothyroidism, affecting the pituitary or the hypothalamus. We talked about this yesterday. What medication can centrally lower the TRH, lower the TSH, and can lower the T4? Here, centrally. Dopamine and steroids, right? Yeah. And why is that steroids? Yes, because in the thyrotropes, what are they? In the pituitary, right? Where the TSH is produced in the pituitary, those cells are sitting next to, in anatomy, in the histologies, right? You have histology, right? So those lines of cells of TSH sitting next to ACTH. They're neighbors. So sometimes they can get affected because of that. So the TRH, yeah. So steroids have a negative feedback on that. Yes. The glucocorticoid GRH, right? Yes, in the hypothalamus, but also affect the same cells, the TRH. So that's why they can affect each other. Management of hypothyroidism, straightforward levothyroxine. And we monitor these patients every 4 to 6 weeks to reach an equilibrium of the levothyroxine. We need that time. Mixed edema, very high TSH, very low T4. And this is a very severe hypothyroidism because of long-standing hypothyroidism not treated for a long time and due to accumulation of mucopolysaccharides in subcutaneous tissue. And patient present with everything is low, hyponatremia, hypoglycemia, hypotension, hypothermia, hypomentation, coma, confusion, heart failure, anemia, everything is going down. And it has very high mortality. Treatment, because if you give levothyroxine, high dose, you think because of severe hypothyroid, give them too much thyroid hormone, cardiotoxicity. Okay, because they can first, why? Because they cannot get rid of the medications. When you are hypothyroid, medications stay longer. The half-life of any medication stay longer, and the thyroid and all the cells are very hungry for the thyroid hormones. So you give levothyroxine to the heart muscle when it didn't have it for a long period of time, and goes into arrhythmias. So very carefully treat these patients in the ICU. Subclinical hypothyroidism, when to treat? Positive TPO antibodies in some patients who wanted to get pregnant if the TSH is high and they have TPO positive antibodies. Patient have a goiter, didn't like the look of the goiter, or they have compressive symptoms and normal T4, T3. I might give them levothyroxine to lower the TSH so the goiter can shrink a little bit. Pregnant lady, of course, I have to treat because if the baby doesn't have thyroid or hormone production for 3 months, so I have to treat them even during pregnancy. The end of pregnancy, infertility, always check for the TSH and try to correct. Patients, male patients, elderly, more than 10, I treat. Between 5 and 10, if elderly, I avoid treating those patients, especially if they're cardiac patients, because of the cardiac toxicity of the thyroid hormone or thyroid medication. Patients are obese or unable to lose weight with high TSH, we treat. Thyroiditis, we talked about that, different type of thyroiditis, but this phases of thyroiditis, we call it triad of thyroiditis. The horses are outside the barn because of the walls of the thyroid is broken, damaged. So the T4, T3 goes out. So the early in the game, you'll have hyperthyroidism for a few weeks. Then the production, because the walls are not there, the thyroid hormone function goes down. So you can have neutralization of the numbers of the thyroid cells going out, weaning down the symptoms. So hyperthyroidism followed by euthyroidism, and can go down to hypothyroidism and continue as hypothyroid or recovery. So there is a spectrum of triad of symptoms: hyperthyroid, normal thyroid, and euthyroid. Thyroid nodules, very common. 95% of the nodules are benign though, and 5% only are malignant. And prevalence of thyroid nodules in women is 3 times more than men. So case number 2, one of the gentlemen. Please, can you read this?
37-year-old man with a 2-centimeter right thyroid nodule that was non-tender found incidentally on neck MRI. History of mental radiation for Hodgkin's disease 10 years earlier. He has no symptoms of hyper or hypothyroidism. What's the next step? Eventually,
So 2, while we do the ultrasound, we have MRI and show the nodules.
ultrasound better.
Yes, superior to the, give us more information. and also to help us when we do the ultrasound guided FNA if we have to, they need to give us more information. Then, so we have to confirm because sometimes even though it says it's the thyroid, but it could be parathyroid, could be a lymph node, unless you do the thyroid ultrasound, it's so difficult with CT. This MRI is much better, superior to CT, but if you want CT, you have more reason why you do thyroid ultrasound. Okay, you have to characterize the nodule better, and you do that before you do the TSH. TSH is always right. Okay, but if you want to confirm the nodule, actually the thyroid nodule, from the imaging, you pick the thyroid ultrasound. So the best test for anatomy and size of the thyroid is the ultrasound, and blood flow characteristics can help us to differentiate with thyroiditis, thyrotoxicosis, hypothyroidism, greatly improved cytological yield of FNA biopsies. 50% of people has imaging detected one or more nodules, and a strong bias towards real-time imaging in endocrine clinic. Because here in Saudi Arabia, we don't have, in the US, the treatment of, like in my clinic, I have my ultrasound machine next to me all the time. So I do bedside ultrasound on almost all my patients that I detect thyroid nodules or anything. I just do bedside, and then if I can make a full ultrasound report if I find something. If I don't find something, then I don't send patients to radiology. That's what I mean. Like I have my own ultrasound. So we have a strong bias towards real-time imaging in endocrine clinic. And this is how the thyroid ultrasound give you the information. You always have to find your boundaries. Anything in the thyroid ultrasound that looks like dark is because of gas or fluids. So here you see that the one in the middle, that's the trachea. The lateral dark spots, hypoechoic spots, are the blood vessels, whether it's a carotid or the jugular veins. So once you see that, you know that you are in the neck, and this is the thyroid. The thyroid is a gray butterfly structure in the middle, and the esophagus in the left side is behind the thyroid. Everything in the thyroid image on the top, that's anterior. Anything in the bottom, that's posterior. But because it's a 2D, the image cannot show you posterior. So it show you either top or below or bottom, but actually it's anterior and posterior. So everything in the top, that's skin, muscles, trachea, and the thyroid, and way in the back, that's in the bottom. So if you want to look for the parathyroid gland, you find it where? In the image, in the bottom of the screen, because it's the posterior to the thyroid. Okay. And if you see parathyroid in the ultrasound, that means it is enlarged, because normally we don't see a parathyroid. They're very tiny, pinpoint parathyroid glands compared to the thyroid. Very small. So in thyroid ultrasound, we never see parathyroid glands, normal parathyroid glands. It's always an adenoma or hyperplasia. Okay. Case number 2, one in the back. Can you read, please? Anybody? Yes.
Which of the following tests will you order next? You order TSH.
Yes, you find in the ultrasound there is a nodule. You confirm what I've seen in the MRI. Then you do a TSH. And why we do TSH?
Period state,
Yes, and we have a nodule, so you want to know if this is hot nodule or cold nodule, right? So if it's a hot nodule, the TSH will be
No.
high or low?
No.
Low. If the TSH is low, this most likely is hot nodule. So we save ourselves a biopsy. If the TSH is high or normal, if it's high, then it could be hypothyroid. That's another thing. But it's normal. This is a nodule that's need biopsy, right? If the TSH is low, if the TSH is low, then could be hyperthyroid state because the TSH low because of the high T4, but the high T4 is coming from the whole thyroid or coming from the nodule. We don't know. That's why we do thyroid uptake to see if this is like hyperthyroidism, the whole gland is hyperthyroid, like Graves' disease with the cold nodule, or this is a toxic nodule and the rest of the gland is not active, right? So if we have a nodule, we have to do TSH. If the TSH is low, then the next step would be thyroid uptake and scan to differentiate whether it is hot nodule or a cold nodule. But if the TSH is normal or high, alhamdulillah, we don't need to do thyroid uptake. And this is patient straightforward. We just do ultrasound guided FNA. If the thyroid is suspicious on the ultrasound. If it is not suspicious, halas, we don't do anything. So next step, TSH. FNA, we save it for later. If the TSH is normal or high, we do FNA. If the nodule is suspicious, C, thyroid uptake and scan, we do it only if the TSH is low. TPO antibodies can help us if there is, in the ultrasounds, showed goiter, but not a nodule. So the TSH came low. What would you do now? And the nodule was on the right side and showed this type of picture. This is what? Cold or hot nodule? Okay. There is a defect in the right lobe corresponds with the palpable, non-tender right thyroid nodule. What would you do next? FNA of the right thyroid nodule because it was suspicious on the thyroid ultrasound. But still, I have to treat the hyperthyroidism. So this patient had most likely have Graves' disease with a cold nodule. So I have two pathology. Because I have low TSH, I have to treat that. And have a cold suspicious nodule, I have to do an FNA. Because it could be cancer. The most common cancer in thyroid, papillary thyroid cancer, followed by follicular. Then anaplastic, medullary, and lymphoma. If you want to remember something here, papillary and follicular thyroid cancer are the most common. Many patients, and those are the patients we treat with surgery followed by radioactive iodine ablation. Why? Because they produce thyroglobulin. These are the follicular papillary cells. So they respond to radioactive iodine. Anaplastic, from the name, it's anaplastic. It's no tissue. The cells is damaged. It's no longer behave like a thyroid tissue. So it's not going to take the radioactive iodine. Medullary is a cancer of the C cells that produce calcitonin. So it's not going to be responding to radioactive iodine. And lymphoma is lymphatic tissue also is not responding. Investigation for any cancer in the thyroid, ultrasound followed by FNA, CT scan, MRI, PET scan, serum calcitonin, if we're thinking of medullary thyroid cancer, and CA, radioactive iodine scan, treatment, total thyroidectomy, and wide lymph node clearance, because thyroid cells can migrate to the lymph nodes, and from there can go to the body, give you stage 4 metastasis. Radioactive iodine ablation for papillary and follicular high-risk patients only. And also part of the treatment to give levothyroxine in those cancer patients to do what? Block a TSH stimulation of any remaining thyroid tissue. So if patient who have total thyroidectomy followed by ablation, I have to give high dose of levothyroxine, not a replacement dose, because they will need a replacement because they don't have thyroid. But I have to give it more than normal most of the time to block any TSH stimulation of any thyroid cancer cells. And to monitor that, I have to monitor the protein of the thyroid, which is thyroglobulin. Periodically, every 3 months, 6 months, once a year, I have to see if there is any thyroid tissue that's still able of making thyroglobulin. And if I find that, I will send the patient again to radioactive iodine ablation. Try to kill all the thyroid tissue in high suspicious cancer patients. Case 3. Any volunteer? Yes, please go ahead.
A 39-year-old female was diagnosed with papillary thyroid carcinoma 1 year ago. Funds were follow-up. She underwent total thyroidectomy and radioactive iodine ablation 1 year ago. Currently, she's on levothyroxine 160 micrograms daily. As part of her preparation to look for recurrence, she was taken off thyroxine.
Okay, stop here. As part of preparation to look for the recurrence. Recurrence of what? Thyroid cancer. I am putting my foot on the brake, giving high dose of levothyroxine. That means TSH is low, right? Keeping it very low. So I'm putting my foot on the brake. I don't know if there is any cancer cells. So I release my foot from the brake, stopping the levothyroxine for a while. TSH goes up, thyroglobulin should go up also. If there is any thyroid cells, cancer cells. So that's what we do in clinic in practice, in monitoring those cancer patients for a while. We stop the medicine. Sometimes not only stop the medicine, we give what? We give synthetic TSH injection. And that will stimulate any thyroid cells in the body. So we can do the cheap way, stop the levothyroxine for a while, and patient becoming hypothyroid for 2 weeks, 3 weeks without any treatment. Okay, they're not happy about that, of course, but there is medicine, thyrogen, expensive. We give it to patient, insurance approve it, but in 1 day or 2 days, TSH will go to 200. Very high TSH, very effective, and we can check the thyroglobulin in 48 hours and see if we see any thyroglobulin. But to check for thyroglobulin, you always have to check for thyroglobulin antibodies. Because if you have antibodies to thyroglobulin, it will combine thyroglobulin and it's not showing in the blood. So this thyroglobulin test is not valid unless the patient is negative for thyroglobulin antibodies. It's monitored. And we go forward past this point and we do PET scan. We treat it just like thyroid cancer. We just do PET scan. So unfortunately, some few cases, they show positive thyroglobulin antibodies and we cannot do this whole thing. But if they are negative for these antibodies, then we stop the medicine or give TSH and check for the laboratory findings. The free T4 will go down, of course, because we're stopping the levothyroxine. The TSH will go very high because we stopped it. And thyroglobulin level in this patient was undetectable. So it's very good, right? Very reassuring. And if we do imaging, I-123 Whole body scan could be negative. Neck ultrasound was also negative for recurrence. Is this patient in remission or does she have the disease? Remission. Because thyroglobulin is undetectable, ultrasound and iodine scan is negative, thyroglobulin is undetectable, means there is no malignant thyroid tissue, so this patient is in remission. Case 4, running out of time, so I'll go quick. We have 2 more cases. 50-year-old woman admitted to the ICU with unresponsiveness, bradycardic, hypothermic, TSH more than 150, 3T4 is undetectable. What's your diagnosis? Myxedema, severe form of hypothyroidism. Case number 5, 38-year-old woman presents to your clinic with fatigue, constipation, and weight gain. On exam, you find a firm, mild diffuse in parathyroid DTR receptor reflexes +2 with delayed return phase. TSH 84.5, very high. What's your next step? What do you do to this patient? You treat. Do you need more investigation? Do you need to prove anything here? Patient is hypothyroid, right? You want to measure antithyroid antibodies? You begin thyroid hormone. You want to do all order radioactive thyroid uptake in hypothyroid? Is useless. Order ultrasound. FNA for what? So we treat this patient. 6, 35-year-old woman presents to her clinic with 5 kilogram weight loss. The last 2 months, increased sweating, anxiety, difficulty concentration. She has 6 months old son. So she just had a baby. She has pulse is high, no exophthalmos, but she has stare and lid lag. Thyroid, non-tender, but normal, positive tremors. TSH was low, T4 and T3 were high. What's your diagnosis? Most of the time, postpartum thyroiditis is self-limited. And we monitor them or treat them like yesterday I saw a patient with a similar presentation, but she has thyroid receptors, antibodies were positive and TPO were positive, and she had a baby like 6 months ago. And she came actually asking for weight loss medication. So we do the TSH and it was low, 3 to 4, high. So we went for the antibodies. I gave her methimazole 15 milligram. She came yesterday, 1 month later, with complete block of the thyroid hormones, like undetectable thyroid hormones, and TSH was 68. I gave her only small dose of antithyroid medication. Those patients, we usually tell them, the minute you see that you gain weight or you switch from hyperthyroid, because she has symptoms, she has tremors, palpitations, and all that, to come back and do the check very quickly, because the effect of the antithyroid medication happens within few days. So if you overblocking, you can send the patient to hypothyroidism. So in many cases, we don't give them treatment for those patients. Postpartum, we monitor them unless they're symptomatic. We give them beta blocker. I should not have given the antithyroid medication, okay, without asking the patient. I asked the patient, but she didn't come the whole month of Ramadan. Case 7, 67 years old woman with new onset atrial fibrillation. Goiter with 3 distinct lumps. TSH is low, 3 to 4 and 3 T3 are normal. This is what? Subclinical. Do we treat or not? Because she's 65 and we are afraid of osteoporosis and cardiac toxicity. So this finish our thyroid and parathyroid for this week. Inshallah, next week we start diabetes, clinical presentation and complications. Any question? All right. Allah That's